Is
Good
that
afternoon. I'd like to welcome and introduce Dr. Robert Murphy, Executive Director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine, who answers your COVID questions every Wednesday on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be answering viewer-submitted questions and addressing the latest through today, October 27th. We invite you to submit your questions via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. And leading the discussion today is myself, Sophie Bukowski, a student research assistant with the Institute. So Dr. Murphy, I'm going to start with some updated COVID statistics.
great?
In the
Thank you,
United
Sophie.
States, yesterday we saw 80,000 positive new cases, with a 7-day average being at about 37,000 new cases every day, with a 4% decrease over the last 7 days. Our booster shot rate still sits at about 35% in the United States. The hospitalization rate stayed flat in the United States overall, but it is overall increasing a little bit, and the death rate decreased by 5%. In Illinois, we saw roughly 2,369 new cases yesterday, with our 7-day average being at about 2,000 cases. We are seeing a 35% increase in cases over the last 14 days, with hospitalizations increasing by 11% and the death rate increasing by 31%. Okay, so is this like the winter wave, Dr. Murphy?
No, the winter wave hasn't started yet. We're still in the fall. But what we're seeing in pediatric and in some adult cases, that there's all sorts of other things going on. The flu season has started a little bit early, so we're starting to see flu cases already. Normally that doesn't start till November, December, but they are appearing. And in pediatrics, the children's hospitals and the wards for children are really pretty full with kids that mostly have respiratory syncytial virus, RSV, or enterovirus D65. And not necessarily COVID or the flu, but these other viral infections. And so what we're afraid may happen is that once the flu season takes off, and COVID probably has at least somewhat of an uptick this winter, because every winter it does so far, that we're going to have this kind of double whammy or triple whammy of infections. So we can prevent or at least prevent severe disease anyway, taking the COVID vaccine for kids approved over 6 months of age, and for flu shot in kids is approved. That if we do that, we'll be able to tamp down this kind of triple wave infection that's likely to come. So we have to prepare now. So it's important to get everybody vaccinated before the winter really sets in, and these cases are expected to go up.
Totally. Well, wonderful. And now for our first headline. The Pfizer vaccine has now said that the list price could be about $130 per dose once the government contract ends. So what does this mean for the general population?
Well, from a public health standpoint, if the payment is going to be shifted to the person during a pandemic, and we are still in a pandemic, is absolute insanity. You can't put the fiduciary component into this to the individuals, because you're immediately, people are not going to take the vaccine, even if the insurance pays, because there's so many uninsured people and underinsured people and co-pays and confusion. As soon as people hear, oh, I have to pay for it, you know, it's there's going to be a drop off in the number of people, and that's going to hurt everybody. So this is not a wise thing to do. If we go that route, and this is a congressional issue, it's Congress, it's not the president, it's not the CDC, it's, you know, it is Congress that's not approving this. If it does get to this point, the good thing is that there are 4 vaccines that are out there. 3 of them can really safely be used, and there should be a price war between the 3 of them. You have Pfizer, you have Moderna, and you have Novavax. All of them work about the same. And Novavax, very underutilized, kind of a slightly older technology. It's the old-fashioned technology, the older fashioned, you know, protein particles, subparticles. You know, how other vaccines have been commonly made for many years. Some people feel more comfortable with that, but they've only sold like 500,000 doses of the vaccine. This is it's a very small uptick, or not 500,000, but but not very many. so there'll be a price war, and people can change and go from one to the other. So that will be good. But I still think that the problem is that it's too early to be able to putting a charge on these vaccines. If for any kind of epidemic or pandemic, if you do that, you will lose a big chunk of the population will not take the vaccine. This is just bad public health.
Right. Yeah, absolutely. And now going into our second headline, cases of BQ1 and BQ1.1 COVID variants are doubling in the US as Europe warns of the rise. So in Europe right now, it has taken over. What do you think will happen in the US now?
Yeah, so this is the same old story happening again. These new variants come, they can evade some of the treatments that we have out there, and they are breaking through and are more contagious than the last variant. Now, the good news is that it doesn't look like they're causing any more severe disease. I think the severity of the disease is actually the same or a little bit less, but you have a doubling of the number of cases, doubling or more so every week. And so you know how that goes. 2, 4, 8, 16, 32. It just keeps doubling. It goes very, very quickly. So right now, in the ones that they've checked, it's 17% of all the virus are these new ones, this BQ1, BQ1.1. So the new variants are coming. This is not a big surprise.
No, absolutely. So going right into our third headline that ties closely into that headline is that the Omicron subvariants pose a new threat to people with immune deficiencies. So what does this mean for the immunocompromised population?
Well, it's not sure how well these antibodies actually work. The antibody treatments work for the new variants. So supposedly it's less so. The other thing is that the antibodies that are out there are underutilized, particularly in immunocompromised patients. Evusheld, which is the one that the injection lasts for 6 months, it's really designed for immunocompromised people that have trouble making antibody. This gives them a big load of antibodies every 6 months. This is very underutilized. And people that have immunocompromised conditions, which is estimated to be about 7 million, only about 500,000 have taken it. So it's way, way, way underutilized. And so if you have an underlying immunocompromised condition, you should consider Evusheld. It's going to help you. Now, as the new variants are coming, that activity may go down, but at least it's something, and will protect you from at least some. It'll give you some protection.
Absolutely. And now for our last COVID headline, men died from COVID-19 at a much higher rate than women did in pandemic's first year. Okay, what does this mean for the contrast between the death of men and women right now due to COVID?
Well, it's not that unusual, like in tuberculosis, which is not very common in the United States, but it's very common in many parts of the world, such as sub-Saharan Africa, that men get tuberculosis more often. So men are more likely to get it, whether it's environmental or just a sex hormone thing or whatever. It's probably a combination of things. But yeah, these increases in the people dying from COVID is 50% higher for men, and in some places it was even as high as 78%, depending on the geographic area. So this is just of interest, and it means that we need to focus more on making sure that men are protected and treated with the drugs that are available today, which are also underutilized. And vaccinated, which is also underutilized, and boosted, which is underutilized. All these things come into play, but you want to go where the sort of the action is, where the big problem is. And we've got to start looking at men as another high-risk group, and that's half the people. And then, as we talked about last week, it's white men in particular having the biggest problem now. So it's underrepresented minorities actually are doing better in terms of vaccine uptake and outcomes. So
yeah,
we've got to be careful. This is still there. There's
Absolutely.
over 300 deaths per day still in the United States. This pandemic is not over.
Yeah, absolutely. And now for our one and only COVID question, and one that I feel like has been asked everywhere, is should I get my booster and flu shot at the same time in different arms? How long should I wait if I should wait, etc.?
Well, you can do it at the same time. As far as overall safety is concerned and the efficacy of the vaccine, you can give them on the same day. However, the local effects of the vaccine, the pain in the arm, the headache, the malaise that is associated with vaccines may be worse when you give them both together. So from a practical standpoint, you can give them at the same time, but you may have more side effects. So what I'm telling my own patients and what I'm doing myself is take one of them and wait until the side effects from that one have completely gone away, and then take the other one. You can, right now you can split it by a week or 2 weeks or whatever. You can do the flu shot first or the COVID shot first. It doesn't really make any difference. But the flu is already here. So you've got to get both of these things. The bivalent new COVID vaccine is very good. It will offer more protection against BA4 and 5, and maybe these newer variants. So that remains to be seen. But make sure you get them both. And I'm recommending that you split them apart. It'll be better tolerated.
Wonderful. Well, those were all of our COVID questions for today. Thank you, Dr. Murphy.
All right. Thank you, Sophie. We'll see you next week.